upper chambers are the atria, the lower chambers are the ventricles, right side versus left side. We've got the one-way valves between the atria and the ventricles, your tricuspid, your bicuspid, and then we've got our one-way valves that carry blood out of the heart. The right side of the heart, remember, carries blood to the lungs, so it can pick up oxygen, and then it brings it back to the left side of the heart. Now it's fully oxygenated, and the left side of the heart sends it to the aorta, which then goes to the whole body. And we did talk about the coronary circulation, right? We said the first two vessels that come off the aorta come back to the heart and feed all these thick layers of heart cells, and it's within the coronary arteries that we get fatty blockages that stops blood flow, resulting in death of cells as a heart attack or a myocardial infarction, which then damages your heart. Because remember, heart cells do not divide. They do not divide and they do not repair. So I think that's where we ended up. Is that correct? Something right in there? Okay. So this part of the rest, this next section we've talked about in lab, which is nice. So we got a little background information on this. Cardiac cycle is one full beat of the heart. It includes a systole cycle and a diastole cycle. Systole refers to the contraction phase. Diastole refers to the relaxation phase. And when we take blood pressures, that's related to these words. Your top number in blood pressure is the systolic, right? The bottom number is the diastolic. What that means is pertaining to systole and pertaining to diastole. So systole is the contraction phase of the heart and diastole is the relaxation phase. And the upper chambers, the atria, each atrium has a systole phase and a diastole phase. And the ventricles have a systole phase and a diastole phase. And they alternate. So when the atria are in systole, the ventricles are in diastole, so that when the atria contract, they completely fill the ventricles with blood. Then the ventricles contract, and the atria relax, and the ventricles send the blood out the big vessels to the lungs or to the body. And there has to be a delay. And when we talk about the conduction system, we know that there's a delay because of that passage of impulses through those conduction fibers. What's interesting is that the ventricles are almost 3/4 full before the atria ever contract. We mentioned this in lab. That's why people can actually live with atrial fibrillation, where their atria aren't contracting well, because the blood flows into the ventricles pretty well without the atria ever having to really do anything. So blood comes in to the atria and it just kind of flows right through the valves, comes into the atrium, flows through the valves. When the atria contract, it completely then fills the ventricles. But even if it doesn't completely contract, there's still good volume of blood here, which can then, when the ventricles contract, send it out and maintain appropriate oxygenation and such. Our valves are one-way valves. We do not want our blood to come into the ventricle, and then when the ventricle squeezes, it goes back up to the atrium, because then it would just go back and forth and back and forth and back and forth. We don't want that. We want it to come in, go through, this valve closes, and then it's forced through that one. Same thing on this side. Blood comes in here. When the ventricle contracts, it squeezes or closes this valve and pushes the blood through the other one. So it's one-way flow through the heart. So remembering our conduction system. Let's review our little conduction system. SA node is the pacemaker. Other way is where the beginning of the heartbeat starts. If you take a heart out of the body, it will continue to beat in your hand until there's no more blood flow and oxygen to the cells of the heart and they die. its own. Your brain doesn't tell your heart to contract, it's your conduction system. And we said of the heart cells, about 1% of the heart cells make up the conduction system. And they're not contractile, they're not a muscle cell, they're more like a neuron. They kind of look like a neuron, they function like a neuron. Sorry. And we'll talk to the heart cells and tell them to contract. So the SA node sits in the upper right atrium, is otherwise known as the pacemaker of the heart, because it starts the beat. And what it's going to do is it's going to automatically depolarize about 60 to 70 times a minute. That's your heart rate, right? We did our heart rate in lab, 60 to 70 beats per minute or so. So the SA node has fibers, neuronal type fibers that come off of it and branch to the atria and then tell the atria, time for you to contract. Then that impulse is connected to the AV node, and when it hits the AV node is going to zoom it through a big bundle called the bundle of His, through the walls of the ventricles, the interventricular septum is going to branch to the right and left bundle branches. That's going to zoom down to the pointy end of the heart, and then at the pointy end of the heart, we're going to have all the individual fibers called the Purkinje fibers that are going to go and tell the ventricles to contract. So there's a slight delay because of its anatomy. SA node goes first, atria, AV node, zoom, 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 Purkinje fibers, ventricles. Now, we didn't talk, well, let's look at this real quick.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
So the nodes just causes the atriums and the ventricles to contract, and that's what pushes the blood through the valves?
The contraction of the heart, yes. So I got to review a little bit of anatomy. We didn't talk a ton about, I gotta see if I've got that picture. That's an okay picture. Skeletal muscle cells, remember, are all the same length and they run parallel to each other. Right? They're all like this. They run parallel to each other. They contract like that from the ends, right? Sarcomere, string, blah, blah, blah. Cardiac muscle cells, are short. They're very tiny short. They are connected end to end, like so, and side to side, and they can branch. Skeletal muscles don't do that. Cardiac muscles also have little holes between them called, anybody remember what these are from anatomy? Gap junctions. And then there's proteins that hold the cells together called desmosomes, so they don't fall apart from each other. You can actually see this line When you look at a muscle cell under a cardiac muscle cell underneath the microscope, it's called the intercalary disc or the intercalated disc because it's got lots of proteins that hold the cell together. You can actually see where the cells end from end to end. It stains dark. So what's going to happen here? Well, what else do we have to say about this? There's less sarcoplasmic reticulum than there is in skeletal muscle cells. There's a little bit less. What's sarcoplasmic reticulum do? See, there's a reason I had you learn all that. Stores calcium, but there's not as much of it. So what we're going to end up having to do, in order to bring in enough calcium, we're going to have to bring in some calcium from the outside. So it's a little different. The anatomy is a little different. And then the other thing that's different is that, remember, in skeletal muscle cells, each skeletal muscle cell is talked to by an individual motor neuron, right? By a motor neuron. So in order for this muscle cell to contract, this motor neuron releases acetylcholine, tells that muscle to contract. This muscle, same thing. Acetylcholine is released by the motor neuron, tells it to contract. These may be the same neuron talking to the two cells, or they might be different. It just depends. There is no neuromuscular junction here in cardiac muscle cells. There's no motor neuron that's going to tell the cardiac cells to contract. What is going to tell the cardiac muscle cells to contract is the conduction system. So what we're going to have is fibers of the conduction system coming from the SA node are going to sit next to heart cells and have gap junctions. You're going to have little holes in between. And what's going to happen is the fibers from the conduction system, whether we're coming off the SA node or we're the Purkinje fibers, either way, we're still going to, this is how they communicate with the muscle cells. They sit next to one cell. The impulse is going to travel through the gap junctions and through these gap junctions and through these gap junctions and through these gap junctions and these gap junctions. And so while this cell is going to have an action potential, because this one, the conduction system told it to, it's going to pass through this cell and this cell and this cell and this cell, and they're all going to have an action potential and they're going to contract as a unit. So not every single cell is told to contract by the conduction system. A few are, well, there's a bunch, but not as many as the cells there are. And so because we've got these holes, we're going to spread the impulse from cell to cell to cell, which allows for our atria to contract in a nice unit, in a nice wave, bloop, bloop, together. And the ventricles, the same thing. You're going to contract together. Myofibrils, sarcomeres, set up just like skeletal muscle. Just like in skeletal muscle. All the myosins are lined up together, the actins are lined up together, cardiac muscle is striated. When you look at it under the microscope, it looks striped. Remember, smooth muscle does not look that way. Those are set up differently. Make sense so far? Okay, a little different anatomy than okay. We got pictures. More pictures. other difference between the sarcomeres, we're going to draw here. Oh, let's see. Cardiac muscle cells also have T-tubules. We'll draw those in. Can't forget about those. That's T-tubules. They've got just some wussy sarcoplasmic reticulum, not as extensive. So we'll make it smaller. But the myofibrils and our myofilaments are pretty much the same. There's a little bit of a difference. What's this? What's this? Z-disc, what's this? What's this? Can't forget about this stuff. What are these? Actins, what are these? So this is familiar, right? Or did you dump it out of your head after last week? I hope not. Now what? TT complex. So cardiac muscle has a troponin tropomyosin complex just like skeletal muscle cells. The troponin protein is a little bit of a different form than in skeletal muscle cells. One of the things that they can do if you come in and you think you've had a heart attack or you're having a heart attack, is they can do a blood test and look for troponin levels. And if it's a troponin that is a heart troponin, that means that your heart cells have blown up and that protein is now in your bloodstream, and that's an indicator that, yes, you've got some damaged heart cells, you're having a heart attack. You know, if it's a skeletal type troponin, then that's different. So it's one of the tests that they can look for. All right. So, first thing that's going to happen is our SA node is autorhythmic, meaning about every second, it's going to automatically depolarize and send an action potential, or have an action potential, which is going to travel through the cells. So the resting membrane potential of our SA node is minus 60. Minus 60. What's interesting is that the SA node fibers, SA node conduction system fibers, the SA node specifically, has leaky sodium channels. Has leaky sodium channels. So if it has leaky sodium channels in the membrane, we've got little leaky sodium channels. Which way is sodium going to leak? In or out? In. Where does sodium always live? Outside. So if sodium is going to leak in, what's that do to my resting membrane potential? We depolarize. We're going to depolarize up to minus 40. Minus 40 is threshold. What always happens at threshold? Which means
the impulse will continue going.
how?
I don't know how in the heart.
Well,
Voltage gated.
voltage gated sodium channels open, right? As soon as you hit threshold, we open voltage gated sodium channels. So our voltage gated sodium channels are going to open, and which way is sodium going to go? In. We're going to flow tons of sodium in, right? And we're going to rapidly depolarize. That sodium leaks through the holes. Resting membrane potential of our heart cell is, your note says, minus 90. Minus 90. There is no threshold. So this is like skeletal muscle, there is no threshold. So as soon as we hit minus 89, what opens? Voltage gated sodium channels on my heart cell, right? And so we're going to flow sodium in through our T-tubules, cell membrane. So we're going to depolarize very rapidly because of all this Sodium coming in, right? So sodium's coming in more in our cardiac cell. That rapid depolarization is going to open up another voltage-gated channel on the cell membrane of the cell, which is a voltage-gated calcium channel. Calcium is going to flow into the cell. We like to push calcium out of the cell. We like to push it in the sarcoplasmic reticulum. We don't like it floating around the cell. So calcium is going to come in from the outside. That's going to cause the depolarization to go even faster. When calcium comes in from the outside, that's going to help calcium be removed or open up voltage-gated channels on the sarcoplasmic reticulum. That process of calcium coming in from the outside to help the calcium be released from the sarcoplasmic reticulum is called calcium-induced calcium release. Calcium coming in from the outside helps the calcium be released from the sarcoplasmic reticulum. Okay? They work together. Because I told you, we don't have a ton of sarcoplasmic reticulum here. There's not enough calcium to do its job to move, the TTs. What's calcium's job?
Bind to the TT.
Bind to the TT complex. Do what?
Move it.
Move it so that we can have our
Power stroke.
power stroke, bind and pull and bind and pull and bind and pull. Okay? Thankfully, we've got magic numbers here. We're going to depolarize to plus 20. Plus 20 is going to
Shut off.
close our voltage-gated calcium gates. Close or allow for calcium to be pumped back out, remove our calcium from our TT. So we're going to close voltage-gated sodium. 2, we're going to remove calcium from TT. And we're going to close our voltage-gated calcium channels, but they're slow. And number 3, we're going to open up. What else do we have to open up here?
Potassium.
Yes. Plus 20 is also going to open up our voltage-gated potassium channels. And which way is potassium going to go? Out. And what does that do? Repolarizes our cell. Now, here's the kicker. We've closed our sodium gates. We've opened our potassium gates, right? In a neuron, that's all we need to do. Sodium gates closed, no more sodium's coming in. Potassium gates open, we lose the potassium, we bring our plus back down to, our plus 30 back down to, minus 70. Here though, I told you that our voltage-gated calcium channels are gonna close, but they're slow. These are fast, and these are fast. So if these have closed, these have opened, but these haven't closed yet. What does that do to my plus 20? I'm at plus 20.
Oh, it will continue going higher.
It's going to stay the same. It's not going to do anything. If I'm bringing pluses in, but I'm carrying pluses out, what's that do to my plus 20? Nothing. We have a plateau. We're stuck there. Finally, when these slow calcium channels close, now what happens to my plus 20? Now I can repolarize. This is important. With these being open, and these being open, and those being closed, we're bringing pluses in as fast as we're losing them, and so we stay stuck at plus 20. It's called a plateau of repolarization. And that's important for the heart muscle. We'll talk about it in a second. Once these guys finally close, even though they're slow, once they close, then we'll lose our pluses through the voltage gated potassium channels. We'll get back down to minus 90, which will then close those. Who puts everybody back where they belong? Sodium potassium pump will shuttle our calcium back to our SR and out of the cell as well, and we start the process all over again. See why I had you learn the skeletal muscle cell?
So with that, how does it shuttle throughout the other muscles? Is it just the same?
Hang on. Ask that question in another minute. I need a little, like, you know, those tool belts
Yeah.
that has markers on it.
What fibers are those
SA,
now? Oh.
no, conduction fibers. Oops, getting sloppy. I got TTs not connected to anything there. Resting membrane potential of my muscle cell, minus 90. Resting membrane potential of my SA node or my conduction fibers. Specifically, the resting membrane potential that we're talking about here is of the SA node. The SA node is what is going to start the impulse. So the SA node is what has the leaky sodium channels. And then when that has an action potential, it sends it to the fibers, which talk to the cells. Okay? Then goes through to the ventricles, and it continues on. What are these? Gap junctions, gap junctions. Whoops. Gap junctions. All right. Resting membrane potential of my SA node is minus 60. We have some special types of sodium channels here. They're leaky sodium channels. Which way is sodium going to leak? Into the cell. So if we bring pluses into the cell, what's that do to my resting membrane potential? Depolarizes it to our threshold, which is minus 40. At minus 40, which is threshold, what are we going to open? Voltage gated sodium channels on my SA node and throughout my fibers, and sodium's going to come flowing in, and this is where the fibers talk to your cardiac cells. So we've got sodium flowing in through all these extensions off of the SA node that talk to the cells, and sodium flows through the gap junctions into my heart cells, right? When sodium enters my heart cells, I'm sitting there at minus 90. What do we do next? What happens? I depolarize. Is there a threshold here? No. So there's no threshold. So once I hit minus 89, what am I going to open? I'm going to open the voltage gated channels that are on my heart cell, and they're gonna open all over the place, flowing sodium in. Here's where I'm gonna answer that question. When sodium comes flowing in through this cell, guess what happens?
Goes to the other side.
It goes through the next hole, which does what to this?
Depolarizes it.
Depolarize, no threshold. We open up our voltage gated channels here.
So
Right?
more sodium flows in.
More sodium comes in, we flow it into this cell, right? So it's a quick flowing of sodium. It's a quick, since there's no threshold, we don't have to have any like delay. We just open up all these voltage gated channels all over the place. Sodium comes in, we're gonna rapidly depolarize. That rapid depolarization is gonna open up another channel on the cell membrane, which is
Voltage gain calcium.
a voltage gated calcium channel. Calcium's going to enter the cell, and what's that going to do?
Opens calcium channels on the
It's going to allow for the release of our calcium from the sarcoplasmic reticulum. What's that known as?
Calcium-induced calcium.
Calcium-induced calcium release. In other words, calcium is causing the calcium release from the SR. That's what that means. Calcium causes calcium release from the SR. What's calcium do? Moves our TT complex, allows for our bind and pull. All this plus charges from our sodium and our calcium coming in allows us to get to, I'm out of room here, plus 20. Plus 20 is going to do three things. One, close our voltage gated sodium channels. Open voltage gated potassium channels. And 3, close voltage gated calcium. But what's wrong with our calcium channels? They're slow. So these are closed, that's all fine, but we can't repolarize yet because we're still bringing pluses in through calcium. We're trying to pull them out with potassium. So what happens to my plus 20? Nothing until these slow guys finally close, and then we can bring our plus 20 back down to minus 90. Once all the other gates close and potassium is open, we bring our plus 20 back down to minus 90. And at minus 90, our potassium gates will close, and we're ready for another influx of sodium from our SA node. I forget. That plateau of repolarization is otherwise known as a long refractory period. So if we look at what's going on here, here we are at minus 90, rapid depolarization to plus 20. What's coming in during this rapid depolarization? What's causing that rapid depolarization? What ions?
Sodium.
Sodium and calcium. Sodium and calcium are coming in from the outside. bringing us to plus 20, right? At plus 20, I can't reach up there, I'm gonna put it this way. At plus 20, so we've got sodium plus calcium coming in, getting us to plus 20 from minus 90. Up here at plus 20, we're gonna close our sodium. We're gonna open potassium, and we're gonna close calcium, but slowly. So, if these are closed, but that's open and that's still open, we get stuck here at plus 20. Finally, our calcium gates close, and with those closed and those closed, the loss of potassium allows for, right, our potassium gates are still open, and we repolarize. Why would this be important in the heart? Why would it be important for a delay before repolarization?
So it can stay in the pattern that it's given, like, so if there is a mess up, they can fix it.
To allow for like the atrium to fill up or contract and the ventricles like to have the opposite.
That's more SA node. That's more the conduction flow. But think about a heart cell. Okay, here we have a heart cell. We contract, and we have like a kind of long repolarization, a plateau of repolarization. So we contract and we kind of slowly relax, and we contract and
Isn't that way your heart's not beating too fast?
right. If we didn't have this delay, then we would go like this. Repolarize like that, right? We would depolarize and repolarize and depolarize and repolarize and depolarize and repolarize. And what would be the problem with that?
It doesn't fill up with blood.
You can have too fast of a heart rate, tachycardia, the chambers don't fill, and if they don't fill, can they pump enough volume of blood out? No. So this is important. We want to have this. We need to have this. We need to have this slow repolarization so that we can relax, let the blood fill the chambers, and then squeeze it again. Slowly relax, fill them up, squeeze it again. So we can keep that blood flowing where it's supposed to go. Correct. EKGs, we talked about EKGs. P, QRS, and T. What's the P wave mean?
Depolarization of the atrium.
Depolarization of the upper chambers. QRS? Depolarization of the ventricles. And the T is our repolarization of the ventricles. Where did I say the atrial repolarization wave is?
The QRS.
Hidden in the QRS. We can't see it. It's there, it's just hidden. And remember, what we're looking for, this is the electrical conductivity through the heart cells. We're looking at the electrical impulses, which means we're looking at the flow of sodiums and calciums and potassiums. And when those move, we see a change in electrical charge, because that's what electricity is. It's changes in charge. So we can see this. And you guys got to practice EKG stuff, so we're not going to spend a ton of time on that. This image is just showing how the wave looks. So as the atria starts depolarizing in the upper right chamber, we get the little up wave. We finish, or we move it to the left side. We sort of finish the movement. Once we get completely done with the P wave, the chambers are completely depolarized. Remember that the interval is when they're going to contract. Then we're going to do the same thing through the ventricles with our QRS, as well as repolarization of the atria. And then repolarization of the ventricles is shown in our T wave, and that starts at the bottom of the heart and works its way towards the top. this is kind of putting we talked about lub-dub sounds, right? Closing of the tricuspid and bicuspid. So the lub is the closing of these valves, the dub is the closing of these valves. So this video kind of goes over the whole thing.
A single cardiac cycle is made up of the events associated with one heartbeat. Each cardiac cycle takes about 0.8 of 1 second. During each cardiac cycle, pressure changes occur within the chambers of the heart as they relax and contract. As the chambers relax, they fill with blood. This is called diastole. When the chambers contract, the blood is expelled. This is called systole. At the beginning of the cardiac cycle, the atrioventricular, or AV valves, open. This allows blood to begin to flow into the ventricles from the atria. At the same time, the pulmonary and aortic valves are closed, preventing blood in the pulmonary trunk and aorta from entering the ventricles. Ventricular filling is completed by atrial systole, or contraction. This contraction results from a series of events beginning with the spread of action potentials from the sinuatrial, or SA node, across the walls of the atria. This results in atrial depolarization, which is represented by the P wave on the electrocardiogram, also called an ECG or EKG. Atrial depolarization initiates contraction, or systole. Atrial systole is represented by the PQ segment on the ECG. Near the end of atrial systole, impulses from the SA node reach the AV node. At this time, impulses spread from the AV node along the ventricular conduction fibers to the walls of the ventricles. This results in ventricular depolarization, which is represented by the QRS complex on the ECG. The atria repolarize, the walls relax, and they remain in diastole for the rest of the cardiac cycle. Atrial repolarization is not seen on an ECG because it is masked by the QRS complex. In ventricular systole, or contraction, increased pressure in the ventricles forces the AV valves closed. The heart sound associated with the closure of the AV valves is known as S1, often described as lub. With continued contraction, ventricular pressures increase until they are higher than those in the pulmonary trunk and aorta. At this point, the pulmonary and aortic valves open and blood is ejected from the ventricles. Ventricular systole is represented by the ST segment on the ECG. In ventricular diastole, or relaxation, the ventricles repolarize. The T wave on an ECG represents ventricular repolarization. Ventricular relaxation results in decreasing ventricular pressure. During ventricular diastole, blood in the pulmonary trunk and aorta flows back toward the semilunar valves, causing them to close. The heart sound associated with closure of the aortic and pulmonary valves is known as S2, often described as dub. After the aortic and pulmonary valves close, pressure in the ventricles continues to decrease. When intraventricular pressure falls below the pressure in the atria, the AV valves open and the cardiac cycle begins again.
All right, quick little look at vessels. We talked about this in anatomy. Definition of an artery is that it carries blood away from the heart. Definition of a vein is that it carries blood toward the heart. Arteries are much thicker than veins. Arteries have a very thick middle layer, lots of smooth muscle. It's the arteries that maintain blood pressure. So if your blood pressure is high, those smooth muscles in the arteries will relax, opening the lumen. What's the lumen? The hole. And then that's going to cause more space for the blood to flow through, which will drop your blood pressure. If your blood pressure is too low, those smooth muscles contract, which means it puts more pressure in the lumen, which allows for the blood to continue on down the road. If your lumen is this big and there's no pressure against the wall, the pushing behind it doesn't allow for the blood to continue on down the road. If the blood is only half filling the lumen, the heart pushing behind it can't keep it going. So we want to have pressure against the arteries. We want to have that blood pushing against the whole lumen so that when the heart pumps, it keeps it going down the road. Arteries are going to branch into smaller vessels called arterioles, and arterioles are going to branch into the teeny tiny little single cell thick capillary beds. It's at the capillary bed where we're going to exchange oxygen for CO2. Oxygen is going to leave the red blood cell, and then CO2 is going to enter the bloodstream and be carried by the venous system. So the capillaries will then converge into small veins called venules. They'll converge into larger veins, which will then ultimately converge into the largest of the veins, which dump deoxygenated blood back to the heart. The exception to the rule that arteries carry oxygenated blood and veins carry deoxygenated blood is right off or right at the heart. So this vessel here is your pulmonary trunk. That's an artery because it's carrying blood away from the heart, from the right side of the heart. But it's deoxygenated because it's got to go to the lungs. These are your pulmonary arteries. They're going to the lungs. Once they pick up oxygen, they're going to carry blood back to the heart by a vein called the pulmonary veins, and these are now oxygenated. So this is your exception, the only exception to the rule that arteries carry oxygenated blood and veins carry deoxygenated blood. Arteries, we said, have thick walls made of lots of smooth muscle. They open and close based on, or they relax and dilate. Relax and try that again. Arteries have lots of smooth muscle. They relax or constrict to change the size of the hole, which maintains blood pressure. So we're going to branch into the capillary bed. We're going to exchange oxygen for CO2, and we're going to converge into the veins and head back up to the heart. Remember that in our veins, don't worry about meta-arterial, don't worry about capillary sphincters either. We talk about that in anatomy. Remember that veins have valves in them to allow for the blood to keep going. We're so far away from the heart when we get to be the veins that the veins can't feel the push anymore. So the only way we can carry blood back to the heart, especially from our legs, is random muscle contractions where we're going to squeeze the vein, pushing the blood through this valve. When the blood wants to backflow, it closes the valve. We squeeze the next section, we push it through the next vein or valve. Backflow wants to close the valve, and those random muscle contractions send our blood back up to the heart. Arteries are being pushed by the heart. That's why the pressure in arteries is so much higher. Normal blood pressure in arteries is 120/80 or so. Normal pressure in veins is about 16. There's no two numbers there because we don't feel the systole and the diastole from the heart anymore. It's just a solid pressure. 16, which is very, very low. So blood flowing through the veins is pretty slow. Pretty slow. Angiogenesis is just the ability to grow new vessels. We do this all the time. If you gain weight, you need to feed those tissues, you grow new vessels. If you have cancer and you're growing a tumor, the cells of the tumor send out chemicals that say, hello, I need oxygen, and the body doesn't know the difference, so it grows some blood vessels to the tumor. We talked about how, did we talk about, that was anatomy, that if you have a blockage in the heart, back here, if we've got a blockage of our vessels here, and it's not a complete solid blockage, if it closes slowly, and it's slowly blocking that vessel, your heart can actually grow its own bypass. And it does it all the time. And this may ultimately close, eventually, but as long as the heart has reconnected downstream, you're okay. Not that you're, healthy because you're gonna make other blockages. The heart does this all the time. Angiogenesis, the ability to grow new vessels. Lymph system. Last little section is the lymph system. We're going to spend a little more time on the lymph system. Lymph system is a vascular system that we talk about usually during the cardiovascular chapter. It is, the vessels are very similar to veins. They don't have a bunch of smooth muscle in them. They have the valves. So basically random muscle contractions send lymph back up to the heart. And what happens here is that, and we'll talk more about this, you've got oxygenated blood artery carrying blood to a capillary system, right? And then the venous side of it will converge. See if I can do this. Oh, look at me go. To the vein. Right? This is artery. This is vein. And what we're going to do here is we're going to exchange, we're going to dump off oxygen to the cells, and we're going to pick up CO2 into the bloodstream, right? So at some point in the capillary bed, we're an artery side and we're a vein side. Is it the perfect line that says, right here, all the oxygen's been dumped off and we've picked up CO2? No, that's why they always make the capillaries look purple, because it's the process is not perfect there. We dump some off, we pick some up, we dump some off, we pick some up, so there's not a nice perfect line. But we're still getting rid of the CO2. And once, the oxygen, and once we bring in the CO2, now we're considered the venous side. And then those veins are going to converge, those venous capillaries are going to converge to larger veins, which are going to head back up to the heart, so we can get oxygen, we can play this game all over again. Capillaries are notoriously leaky. Capillaries leak. And they leak fluid. They leak plasma. Plasma leaks out of the capillaries. And if it leaks out of the capillaries, what's it now called?
Interstitial fluid.
Interstitial fluid. So I can't call it plasma anymore. So we're going to write it here. And we're going to say it leaks out, and now it's called interstitial fluid, because you got to have a name change. Remember from anatomy? Everything gets a name change if it's in a different location. Liquid portion of blood is plasma. Leaks out of the capillary, it's called interstitial fluid. If we just leaked it out and didn't pick it up, what would happen? What would you have? Edema. Edema is excess interstitial fluid. And this happens all over the body. Day after day after day. Our capillaries are leaky. In the next chapter, we'll look more into that. They leak. We leak fluid out. Now we've got interstitial fluid. Now the liquid part of the blood is outside the vessels, and it needs to get back in the vessels. We leak out so much fluid in a day that we leak out 3.6 liters of plasma into the interstitial space. Do you remember how much blood we have in our body? 1.5 gallons, which equates to how many liters? 5 to 6. We have 5 to 6 liters of blood in the body. 5 to 6 liters. Let's make this easy. Let's say I have 5.6 liters of blood in my body. If my capillaries leak out 3.6 liters every day, what do I have at the end of the day for blood volume? 2 liters. How's that going to flow? It's not. So we have to pick this up and send it right back to the bloodstream. Or let's do it this way, send it right back to the bloodstream. Otherwise, we'd be dead at the end of the day. It wouldn't work. So, what the job of the lymph system is to pick up that excess interstitial fluid and send it back to the bloodstream. So all over the body, we have these lymph capillaries and lymph vessels that pick up that interstitial fluid and they dump it right back into the bloodstream up here at the subclavian veins. And as long as we keep dumping it back in, our blood volume stays at 5.6 liters, or mine does, right? So I start with 5.6 liters, I leak it out, I pick it up, I keep it at 5.6, I send it out, I leak it out, I pick it up, I keep it at 5.6. We don't want to lose that out. Throughout our lymph system, we also have lymph nodes that are a part of the immune system. So the lymph system is a combination between vascular and immune. So as we're picking up this excess interstitial fluid, and we're sending it back to the bloodstream, we dump it through these little nodules called lymph nodes, and inside our lymph nodes, we've got a whole bunch of white blood cells that look for infectious agents and try to fight them. When you're sick, what happens to your glands? You get swollen glands. They're not a gland, they're a lymph node. You get swollen nodes. Infections cause swollen nodes. That's a good thing. That means that your white blood cells inside there have detected the pathogen and are dividing and dividing and dividing and swelling your node and making it painful. That's a good thing. You want that to happen. And pretty soon they'll fight it off and help get rid of it. All right, I just want to introduce a couple of terms here in the next section. Next chapter. So we don't get too far behind. Because we're working on getting behind. Surprise, surprise. Chapter 14. Not too long. Couple of pages. So we'll start a couple of terms here and then we'll finish this on Wednesday. So chapter 14 has more to do with cardiovascular system and the lymph. More of this. It's an extended heart vessel lymph sort of chapter. A couple of terms here. Stroke volume. Stroke volume is the amount of blood pumped by one ventricular contraction. And stroke volume and cardiac output, they're related, they're tied together, and they're referring mostly to the left ventricle. We measure stroke volume, we measure cardiac output of the left ventricle because that's the one that sends it to the body. That's what we're looking at. So the stroke volume is the amount of blood, the volume of blood pumped by one ventricular contraction. So when the left ventricle pumps one time, how much blood is squeezed out of the left ventricle per beat? And on average, it's about 70 milliliters. 70 milliliters. Well, 100 is that much. So it's less than that. Like that much blood. Isn't that weird? That's not very much blood, is it? What is it, like that much? If I had a ball of blood, it'd be like that much blood. Don't you think that? I always think that your heart is just like pumping a gallon at a time, boom. But it doesn't. It pumps little bits many times over the course of a minute. So the stroke volume is about 70 beats per minute. The cardiac output is your stroke volume times your heart rate. So if your stroke volume is 70 mils on average, and your heart rate is 70 beats per minute, what is your cardiac output? That's a multiplication.
1
Oh, damn, that 4-letter word math. Darn it. 4,900 mils. 4,900 mils. And if I want to convert that to liters, what do I do?
Multiply by 1,000.
No, I'm going to divide.
Oh, divide.
So I make it 4.9 liters. How much blood do you have in your body? 5 to 6 liters. So in one given minute, 1 minute, your heart is pumping pretty much your total blood volume every minute. Every minute, your blood travels through the body, your whole blood volume, almost, the whole blood volume, every minute. Which means your blood is traveling all over very fast. So, if I had a heart here, oh, this brings back memories, doesn't it? Good ones, I'm sure. Right side of the heart, left side of the heart. Right side of the heart's going to send blood where? To the lungs. Left side of the heart's going to send blood where? To the body. Right? Through your little valve. Alright, I don't really care about the valve right now. Each side of the heart has to have equal stroke volume from each side. Each side of the heart has to have equal stroke volume for a reason. Let's just look at this example. What would happen if the stroke volume of my left ventricle is only 75 mils, but my right ventricle is 80 mils? This is one contraction. Oh, like that. The left ventricle isn't sending as much blood as the right. What's going to happen?
There's going to be too much oxygen.
Right? So I'm going to send out 75 mils here, but I'm going to send out 80 mils here. Where does the 80 mils go? To the lungs. So we're going to send 80 mils to the lungs. How much comes back from the lungs to the left ventricle? Better be 80 mils. And how much is going to go into the left ventricle? 80 mils. But how much can leave? What's the problem? Where's it going to go? It's just going to sit there. My right atrium's going to explode from all the excess volume coming in, because every time it beats, 80 comes in, but 70 leaves. 80 comes in, but 70 leaves. So pretty soon my right atrium's just gonna, or my left atrium's just gonna go, right, and I'm gonna die? No.
Can cause clots.
Where is it coming from? Where is this 80 mils coming from? Guess where it backs up? In the lungs. So now I've got high pressure in my vessels of the lungs. So my little vessels that surround my air sacs are under high pressure. And guess what happens to that fluid? It fills my air sacs, and what do I have? congestive heart failure. So you've got high pressure in your lungs, high blood pressure in your lungs, pulmonary hypertension. Pulmonary hypertension causes the capillaries to leak more. They leak into your air sacs, they fill your air sacs, your air sacs fill with fluid and you have congestive heart failure, and then it backs up throughout the whole body and you get edema, right? Gotta have equal numbers, either side.
Can't a clot in the heart too? If it's just sitting
No.
there not being pumped?
It's being pumped. But it's not really just sitting there. It's not really causing a swelling. All right, IRAT. Up to that page, Wednesday.